On this case, we're going to restore a tooth that has a large amalgam, tooth number 29 with a BruxZir solid zirconia crown. And you can see that the tooth behind it, tooth number 30, actually has a cast gold crown on it. When the patient originally broke that tooth and the one across from it, the dentist wanted to place cast gold on both those teeth because he was afraid that the patient would break a porcelain restoration. But when we mentioned cast gold one tooth forward, the patient did not want to do that, so a perfect case for BruxZir. We're using our Vita Easy Shade Compact to take the shade here, and it's giving me a reading of an A3. And we'll go ahead and take another reading in the middle third of the tooth, and it's telling me that that is an A2. And so we've got the base shades now for the tooth, and we're ready to be able to anesthetize that tooth. We're going to use the rapid anesthesia technique with the STA unit from Milestone Scientific. There's the PFG gel from Stevens Pharmacy being placed in the sulcus of tooth number 29 with an Ultradent syringe. And then the STA small extra short 30 gauge needle tip goes right into the sulcus. And we will achieve pulpal anesthesia on this tooth in about 90 seconds. And that's going to be our only injection, is this sulcular injection. And that's why it's called the rapid anesthesia technique. Because within about 90 seconds, when we've given about half the carpule of Septicaine, I can set that down and immediately pick up the handpiece and start prepping. So it's rapid and it's efficient. This is the first step in the reverse preparation technique. We're going to break the contact. So it's a 56 burr, carbide burr that we're using to go through the contacts and just create some space. So the goal of the first step of the prep technique is just to gain a little space in between the teeth so we can place our first cord. The cord, as you'll see, will retract the tissue for us and help us show us where we're going to put our initial margin placement. And it's also going to protect the tissue at the same time for the rest of the preparation technique so that we don't nick the tissue at all. You can see we just kind of floss the first cord or the bottom cord into place. This is a size 00 cord, the Ultra Pack cord from Ultradent, and it's a braided hollow cord. So you can see it goes into place relatively easy. You don't have to put too much effort to get this bottom cord down into place because it just kind of collapses into the base of the sulcus. And now this is kind of the key part of the reverse preparation technique, and that is to prep the gingival margin first. That's an 801-021 burr from the reverse preparation technique kit. And you can see we've placed a half circle at the level of the gingiva on the facial and on the lingual as well. So this is going to guarantee an almost perfect margin formation and enough reduction in the cervical third on both sides. And the next step is to place some depth cuts. This is a 2mm depth cutter, and you can see I just went in the central groove right through that amalgam. You can see it's self-limiting. Watch it as it goes down, and then boom, it bottoms out. So it can't go any farther than 2mm. You could stand on the handpiece and it won't go any deeper than 2mm. It bottoms out and it won't go any further. This allows you to lean on it and really kind of press hard on it, and so you can do these depth cuts quickly without fear of going too deep. Here's a 1.5mm depth cut being placed in the axial surface. We don't need to place one in the cervical third because with that round burr, we already have essentially a 1.2mm depth cut. So now that we've got all the depth cuts in place around the tooth, it's pretty much just a race to see how quickly we can get the enamel off and get down to the base of those depth cuts. That's an 856-025 tapered burr, my favorite burr. It's certainly the workhorse of this technique. And really in all the preparation that I do, I love large burrs with large surface areas so that they don't drop down into the tooth or fall down into the tooth. The only problem with them is you can't always fit them interproximally if you're not prepping the adjacent teeth. So we'll go with an 856-016 when it comes time to do some reduction interproximally on the mesial and the distal. So you can see with the 856-025, we're simply prepping tooth structure away till we no longer see the base of those holes. And I can tell you that working in a dental laboratory, the one complaint that I hear from technicians is consistently, why don't dentists reduce more? And part of it is we're trying to be conservative. Part of it is we just lose a reference point. Once we start to prepare the tooth, we're no longer able to see a reference mark of how far we've actually prepared, which is why I love the reverse prep technique, because it's got some depth cuts in it so we always know where we are. This is why I love electric handpieces. I've got it turned down to 6,000 revolutions, and I've got the water turned off as well, so I can see exactly what I'm doing as I go around and finish that margin. Once I finish the margin and smooth everything up, It's time for the top cord. This is a size 2 cord. This is the 2E Ultra Pack cord from Ultradent, and obviously it's bigger than the BruxZir cord, so it's a little more difficult to get into place. And this is the cord that is going to create the space for the impression material. So once we put the cord into place, it's going to sit for a good 8 to 10 minutes to give us some retraction. I noticed that I had nicked the gold crown on the tooth behind it, so this is a perfect time to go in and polish that with some brownies and some greenies before we take the impression. The copper cap goes into place over that top cord, over that number 2 cord, and the patient bites down on it, keeps it isolated for 8 to 10 minutes. And look at that sulcus. In fact, you can see all the way down there. In fact, you can see the BruxZir cord at the bottom of that sulcus, and that's exactly the kind of retraction that we want to see. And that's why it's important to wait for 8 to 10 minutes when you do that. You don't put that top cord in and decide you're in a hurry and pull it out 60 seconds later. You need to get enough retraction to have time for the 20 seconds that it takes to squirt the syringe material in onto the prepared tooth and the adjacent teeth. And then my assistant hands me the loaded tray, the Quad Tray Extreme from Clinician's Choice, my double arch tray of choice. And you can see the nice result that we get there. Little scrap of that bottom impression cord sitting on the impression. We can just pull that right off. We placed the temporary, and now it's been about 7 days, and the patient's back again, and we're going to wiggle off this temporary with a pair of curved hemostats and see what we have underneath. Everything looks pretty clean. Little debris there on the distal that we can go in and wash off, and go ahead and see whether or not we're going to have to do many adjustments on this BruxZir crown. Because it's a CAD-CAM crown and the contacts are dialed in and the occlusions dialed in, we typically don't have to do much adjustment if we make a temporary. If we make a provisional crown that has good interproximal contacts and has a good occlusal stop on it, it's very easy for our dental assistants, or even for us, to polish away those proximal contacts on the temporary, or polish away a spot of centric occlusion on the temporary, and have the tooth move around during the 2 weeks while we're waiting to get the crown back. And if that happens, all these CAD-CAM parameters that have been programmed in for us are really for naught, because the tooth, in fact, has moved during those 2 weeks. Because it's a high-strength BruxZir solid zirconia crown, we've cemented this with 3M SBs Reliax Luting Cement Plus. Could you bond this into place? Sure, you could bond this into place, but we had a prep that had plenty of retention, enough length on it, and we don't need to worry about this crown coming off. So I'm always going to go with conventional cementation, because I know the Reliax Luting Cement Plus has almost zero postoperative sensitivity. So easy to use, so easy to clean up. Just a straightforward, fantastic crown and bridge cement. Had it been a very short preparation or over tapered, you could use a self-etching resin cement like Maxim Elite. And even on the horizon, it looks like we might have some bonding agents, which will help these resin cements actually bond to the zirconia itself on the inside of the BruxZir, since it's a solid zirconia crown. Putting the articulation paper in, having the patient bite together, we see we've got some nice areas of contact on the cusp tips, and we can see that the unprepared teeth, the cuspid and the lateral, have marks on them as well. In fact, I can see marks right by the wear facet on that lateral. And so there it is. That's a solid zirconia crown on tooth number 29. There's no porcelain on that whatsoever. I've always wanted to have a material that was a cast gold in about a shade A2, and that's not what BruxZir is, but we're getting pretty close. If you look at that from the outside, that looks a lot like tooth number 28. Doesn't have as much, surface texture on it, but certainly blends in very well. And if we look at it from the occlusal, it definitely looks better than an amalgam. And if you show this picture to 100 of your patients, they will say it looks better than the cast gold as well. So nice looking restoration, that BruxZir solid zirconia restoration, the crown on tooth number 29.